Welcome to this Alamo Breast Cancer Advocate Chat. My name is Bob Riter, and I'm coming to you from Ithaca, New York, and I am a patient advocate with Cornell University. Today, I'm very happy to introduce our guest, Dr. Chris Miaskowski, who's at the University of California at San Francisco. And I'd like to begin, Chris, if I might, by just asking you to talk a little bit about yourself and how you got into this arena of looking at symptom control.
Thanks, Bob. It's really a pleasure to be here talking with you and the audience today. And hopefully some of my comments will resonate and hopefully will provide some information that people can use. In 2 years from now, 2024, I will be a nurse 50 years. And I worked in New York at a major medical center in the Bronx, Albert Einstein Hospital. And at the time I started, there were no oncology units. And so we began on the unit that I worked on to treat patients with cancer. And probably 4 or 5 years after that, the late 70s, we started an oncology unit officially. And at the time, my dad, pretty much simultaneously, was diagnosed with head and neck cancer. He had cancer of the larynx. And my dad underwent radiation and then had radical head and neck and had re-radiation after that and died in intractable pain. And as a clinician, going back for my master's at the time, pain management was really not well done in the setting of oncology units. And so I decided at that point that I was going to do a fair amount of clinical work trying to improve pain management, and then went back to get my PhD. And when I finished my doctorate, I had the opportunity to get a postdoc really doing in-depth pharmacology in a preclinical science lab studying pain and how opioids work, how drugs like morphine work in the nervous system. After I finished my postdoc, they invited me to join the faculty in the School of Nursing, and the rest is history. I became really, really interested in studying symptoms in patients with cancer, first looking at pain, and then some of the other symptoms that we're going to talk about today. And doing that in people getting active treatment, whether it be radiation or chemotherapy, and now particularly in the area of survivorship, because we've got, 18 million, I think, survivors in the United States today, and trying to understand what's happening with them as they live their lives following cancer treatment.
That's great. I was diagnosed with breast cancer myself about 26 years ago. And the whole notion about symptom control has been slow to catch on. Certainly, we're very focused on pain, and nausea have been big, but there's so many arenas, and the research that you're talking about today is an area that most of us never really thought much about: hearing loss and chemotherapy.
You know, just a comment, in our work with people getting chemotherapy across a variety of cancer diagnoses, on average, patients report 14 symptoms.
Wow. 14
symptoms. And it can go from anywhere from 6 to 25. In our survivor work, and we've just finished a study of people during COVID who have survived cancer, the mean number of unrelieved symptoms is 8.
Wow.
That's huge, huge. And the top ones are 2 that we're going to talk about today, but also fatigue, sleep disturbance, and mood, anxiety, and depression. So we have a lot of work to do in terms of helping people.
Right. At least now there seems to be more awareness of this. That I remember 25 years ago, some doctors would say, "We cured your cancer, don't complain to me about sleep or hearing," or things like that.
If I could talk about advocacy, okay. I think the real issue is the investment by the National Cancer Institute in terms of its total budget in relationship to curing cancer and supportive care. And, I'm hoping that advocates will help, because the amount of money out of the huge NCI budget that supports supportive care, palliative care, is minuscule. And, we're at the point now with personalized medicine or healthcare interventions to really begin to understand the mechanisms that underlie these symptoms. Because if we understand the mechanisms, and we're doing a fair amount of work in that arena, we would be able to treat the patients better and figure out new therapies for them, which is really, really, really important. People are living now. Great news, right? We've made great strides.
It is very much, very much. So let's talk about hearing loss. And I think I heard that when you began this work, you didn't set out to focus on hearing loss, but it emerged from other research.
Yeah, so I think some of the best science is serendipity.
Yeah.
You know, you really discover. So we were engaged in studying, and this was probably funded by the National Cancer Institute, another neurotoxicity, which I'm imagining many of the people watching this program have experienced. It's called chemotherapy-induced peripheral neuropathy. So the way I talk about that is people who get neurotoxic chemotherapy, they're left with this feeling, this dysesthesia. It's kind of like, the way I describe it to people who haven't experienced it is when you are sitting on your foot and it falls asleep and you get that burning, tingling, numbing sensation. That's what people with neuropathy feel all the time. It's bilateral, usually a length-dependent neuropathy, so it affects the legs first, and then in some people it affects their hands as well. And so we really, really wanted to study that in cancer survivors. And we happened to give an instrument that was looking a little bit more broadly at neuropathy that said, do you have hearing loss? Do you have tinnitus? And we were very, very surprised in that study that about 40% of the people self-reported hearing loss and maybe 20% reported tinnitus. And the unusual thing about this study was that we were not evaluating patients with diagnoses that had been reported to have tinnitus, mainly testicular cancer and head and neck cancer. We were studying survivors with breast cancer, gastrointestinal malignancies, lung cancer, and gynecologic malignancies. And I went and I said to my physician colleagues, do you ask about hearing loss or tinnitus? No. And the other unusual thing was most of the literature on hearing loss and tinnitus has been done evaluating platinum compounds. And we had a fair number of participants in our study who had gotten taxanes, the taxane drugs, and or both, a platinum and a taxane. And that wasn't reported at all in the literature. So we were fortunate enough to say to the National Cancer Institute, we wrote another grant, and we were able to bring survivors into our setting to do a complete evaluation of hearing loss and tinnitus, including an audiogram, because self-report is not the gold standard for studying hearing loss.
True.
So serendipity, you know?
That's remarkable.
Yeah.
Now, can I just ask a point of clarification? I know that tinnitus is ringing in the ear. Is that, I guess, mechanistically related to hearing loss? Is it all kind of the same pathway? Or are they?
We don't know. We don't know. Hearing loss from the platinum compounds is probably related to damage to the auditory nerve. But the mechanisms for tinnitus aren't really, really clear. We don't understand them well. Two of the people on my study, Dr. Chung and Dr. Henderson Saves, are experts in tinnitus. And I keep saying to them, what's the mechanism? What's the mechanism? We really, really don't understand it. We do know that in people with cancer, the biggest risk factor for tinnitus occurring is having hearing loss. So they seem to be linked. And men have a higher incidence of both hearing loss and tinnitus. So
interesting. So now that you've identified hearing loss as an issue with chemotherapy, what are the subsequent recommendations? Yeah,
big question. So I think we can have some lessons learned from children. Right, children were probably the first group studied for hearing loss. And the reason is many children who are likely to get hearing loss receive platinum compounds. And children are their auditory system is developing. So pediatricians have been cautious. And prior to administering chemo, they get a baseline audiogram and they follow the participants. So I would love us to have standards in the setting of pre-treatment with chemotherapy to do a baseline audiogram. And then, if we can't do that, at least at the end of treatment, do it. There's a real discordance between self-reported appraisal of hearing loss. You underestimate compared to what the actual test shows. And we saw that. About 30% of our survivors reported hearing loss. When we tested them, it was somewhere between 50 and 70% had hearing loss. And that's known in the general population. It's probably related to a sense of accommodation. It's been interesting in terms of publishing this paper and speaking to other individuals, particularly reporters. I've had a couple tell me that they've been cancer survivors and they attributed their hearing loss, even though their family member was saying, "You're not hearing me," to the fact they were just getting old. There's an age-related change that occurs, but we really need to evaluate this. And given the high occurrence rates in these common cancers, survivors really, would do well to go and have their hearing tested.
Well, yeah. I mean, so many people with breast cancer certainly have had taxanes.
Yes.
It's a big issue.
And in our study, there was no difference in the occurrence of hearing loss, whether you got a platinum, a taxane, or a combo. And I was surprised by that because I thought that the participants who received the combination, we would have a higher occurrence rate of hearing loss and tinnitus, and we didn't find that. So that's a question that remains unanswered. And we have a grant right now in the National Cancer Institute that's going to recruit patients prior to starting chemotherapy. And we're going to follow them longitudinally for a year. And the goal is to try to figure out, measuring both peripheral neuropathy and hearing loss and tinnitus, which one happens first. We have no idea in terms of the timeline. And then is one neurotoxicity driving the other? And what are the risk factors for developing one or both?
Do both things tend to happen in terms of?
We don't know.
Yeah, okay.
We don't know. And we don't know, there has not been a prospective study to look at this. There's been some work in neuropathy in some of the clinical trial groups, but the measurement of neuropathy has not been really, I'll use the word sophisticated, it's been more crude.
Right.
So hopefully we'll get funded to do this big study.
And let me ask I know with hair loss, there's been a lot of interest recently in doing cooling caps to cool off to hopefully prevent the hair loss during chemotherapy. Is there a chance we could do something that might prevent the hearing loss with the chemotherapy?
They've tried some preventive agents. Nothing's worked. And I think part of the reason is we don't understand the mechanism. If you don't understand the mechanism, you don't have a target.
Sure.
And the issue of dose reduction, maybe. But again, the risk of curing the cancer. I think the good news about hearing loss, if there is good news, is the type of hearing loss that patients get from the taxanes or platinums are amenable to a hearing aid.
Oh, good.
So that's the good news. The not so good news is the tinnitus. There are really, there's some non-pharmacologic white noise types of approaches, but there's not good treatment for tinnitus because, again, we don't really understand the mechanism.
Right.
So, we got a lot of work to do. In this area.
Right. Well, certainly awareness is a huge step with this.
Yeah, just asking the question,
I can also see that if you do hearing tests before chemotherapy, it might change the risk benefit a little bit in terms of treatment. That if if I would be at serious risk for losing most of my hearing, that would put things in a somewhat different perspective. It doesn't necessarily change the decision, but it makes you think about it a little bit differently.
I also, I could share an experience. I get my best insights from talking to patients. Uh-huh. And I went to give a talk, and I had not thought about this. You read the literature about hearing loss and this loss of social interaction, not being, because some of what's affected is what's called speech and noise. So if you're in a group in a restaurant, you're going to tune out because you're not hearing the conversation. All right, go to the theater, that type of thing. But I was asked to give a talk at a support group, and I had never had this notion of the issue or the risk from hearing loss in relationship to safety. And there was a woman at the talk. I was there to talk about neuropathy. And there was a younger woman at the presentation, and I had mentioned this early study where we observed hearing loss. And the woman didn't disclose her diagnosis, but she told me that she was there because her doctor had told her to come to the talk because he knew I was going to talk, and that she would learn how to manage her pain post-operatively. So I said to her, well, did you learn that? She said, yes. But then she said to me, I have a question to ask you. I was interested in your comment about hearing loss. And she said, could this be the reason my 3-year-old daughter is saying to me, Mommy, why aren't you answering my questions? And I went back to my audiology colleagues and I said to Jennifer, I said, could this be that she's experiencing hearing loss? And she said, yes, that child's tone, intonation is in the frequencies that were most likely lost. Well, that's important for a woman with kids who has to take care of them to know that she might be having this problem. I mean, you wouldn't think of a, 30-year-old, 25, 30-year-old losing their hearing, but she could get a hearing aid and be able to hear her kid. I think that's really, really, really important. And we need to be, clinicians, myself, next week I'm giving a talk to our nursing staff to say, hey, here's our data. You helped us collect this data at UCSF. Please, what do you want to do with this in terms of talking to people that you see who are either actively getting treatment or survivors? We got to get the word out there.
Amen. And this is all, I guess, is sometimes coined collateral damage from cancer treatment. Lymphedema. I know so many people with head and neck cancers who have lots of problems because of radiation. Right. And a lot of them have dental issues. And it's also sometimes especially challenging because, for example, Medicare generally won't pay for dental care, although it was caused by radiation.
I think the good, and we've got to advocate for that. I don't know how we're going to change the system. We could talk about the politics of healthcare in the United States. We probably don't want to go there. There is news that the FDA is ready or is about to approve cheaper hearing aids. Again, if that's something someone wants, they need to be taught how to use them because there is a fair amount of adjustment that needs to occur. But we need to advocate for this, both the clinician side and the survivor patient side.
Right.
It's really, 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 really important.
And as you mentioned, this is a great role for patient advocates.
Yes.
You've been there, and it's important to speak up about these issues. And so often we think about cancer and cancer research as focusing specifically on the cancer biology, but there's so much more that's affected by the cancer and the cancer treatment.
With this hearing loss, I was contacted by a nurse who, because she had hearing loss from her treatment, was thinking she couldn't work anymore because she couldn't hear blood pressures. She was having difficulties performing, her work activity. And in our neuropathy study, the consequences are significant. We had a Michelin star chef who could no longer cook because he couldn't feel his knives. We had a concert musician who couldn't play anymore. We had truck drivers who couldn't drive trucks because they couldn't feel their feet.
Mm.
So people can lose their livelihood because of this. It's not inconsequential at all. And really trying to put some investment into studying the mechanisms and describing the phenomenon, because the good news is people are living longer. You know, I've seen the change over the 50 years I've been a cancer nurse, which is fantastic. But now we have to work through some of the other issues as well.
Very much. And in terms of pain control, I know you've been involved in pain control for much of your career. It seems like we've made a lot of progress in that field. Is that the correct assumption?
You know, I think 2 steps forward, 2 steps backwards. How can I say this? I think that, I have to say this politically correctly, the war on opioids, the opioid crisis, the opioid epidemic has moved us backwards in terms of adequate treatment of cancer pain. And that's been seen, and it's being reported in the literature now. You know, the good news is when I started, the biggest cancer pain problem was bone metastasis, pain from bone metastasis. We fixed that. We have fixed that with all of the treatments that are now available. The big unresolved pain problem is neuropathic pain. And it's neuropathy, peripheral neuropathy. It's there's a post-surgical pain syndrome that occurs after big cancer surgeries, and it probably occurs in about 25% of people who have a breast cancer surgery, whether it be a mastectomy or breast conserving surgery, radical head and neck, nephrectomy. What am I forgetting? Thoracotomy. And I can tell you that I became interested in this neuropathic pain problem, particularly post-surgical pain, when I was a pain nurse at the hospital that I worked at in the Bronx. And I will go to my grave remembering a woman that we used to have pain clinic on Friday afternoon. This woman was our last patient. She came in, she's probably about 60. She sat there and she told us that she had a mastectomy about 5 years before she came to our clinic. She told us a story that she had been hospitalized 5 times as a postmenopausal crazy woman. Nobody believed that she had pain at the incision site because the incision was healed. She couldn't move her arm. She had a frozen shoulder. And she told us if we didn't help her, she was going to go home and kill herself. And we've studied that problem. We still don't have good treatments for it. It's not the surgeon's fault. It's some type of mechanism that occurs in people. It may be similar to the neurotoxicity that occurs with chemotherapy, but the drugs we have really maybe tone it down. We don't have a good understanding of the underlying mechanisms for the problem, so we don't have good treatments for it.
And then symptom control is a specialty of palliative care, which is a relatively new specialty. Is that growing as it should be, do you think?
Yeah, I'm gonna take the prerogative to say that palliative care is an Americanized term. All right. It grew out of England with Dr. Cicely Saunders, probably in the, I'd say late 70s, early 80s, and it was called hospice.
Yeah.
But we didn't like that term in the United States. All right, it had a negative connotation. And so the doctors in the United States Americanized it to palliative care. I still think there's editorializing. There's delays in instituting palliative care. Many hospitals, academic medical centers have palliative care teams, but there is still some resistance in calling in those teams on the part of oncologists, surgeons, you know. So we need to begin to blend that more. But they're quite effective, you know, and there is good data. You know, you bring up the idea of symptom management. There are studies that show, particularly in the palliative care setting, that effective symptom management can prolong life. People get better.
Mhm.
They feel better, you know? So we need to do more to get that movement going and not have such a dichotomy. You know, it should be part and integrated into care.
Great. So let's say I had a magic wand and could give you $50 million to study whatever you wanted to study. What would that be?
I would like to get the grant funded that we have funded in there right now, because the idea of trying to understand how symptoms track with each other, all right? If our plan unfolds, we will look at, as I said, peripheral neuropathy, hearing loss, and tinnitus. But I also, I'm always so grateful that sick patients answer our questionnaires. We need to understand things like fatigue, depression, anxiety, sleep disturbance. We haven't talked about cancer-related cognitive impairment. That's another issue we're really, really interested in. And with the analytic tools that are available now, we can begin to do two really important things. One is try to sort patients, and I mean that in the best sense of the word. In the context of risk profiling, there are analytic ways now, instead of simply reporting a mean and the variance, that's called the standard deviation, we can group people based on their symptom profiles. So the good news about that is we can find out who has a very low likelihood of getting symptoms, as opposed to people getting a very high level of symptoms. And then we can begin to understand what's the risk factors for the high group. And importantly, what are the protective factors for the group that are low? So that's one thing, trying to sort and profile. But the other thing is, if we follow symptoms, because they tend to co-occur in people, the idea is, if you have a big enough sample, you can figure out which is the symptom that's driving everything else. And theoretically, if we had a predictive model, and we could do that, we could intervene on the one that's driving the trait. That's my dream, okay? I don't know if I'll get that done by the time I retire, but I have a lot of graduate students that I've inculcated this idea in, and hopefully we'll be able to figure that out, because that's the part that would make a difference, right?
Boy, if I had that magic wand and $50 million, I would give it to you.
Great. Well, the advocates on this call should really advocate to the NCI to put more money into supportive care research, so we can get some of these questions answered. Boy, that's how we'll make progress, you know?
Absolutely, and this is so important. I know too many cases of situations in which the patient's cancer was cured, but the patient was miserable.
Exactly. Yeah, the survivors and the family's not happy. They're suffering with the patient as well, you know. But we'll make progress. We will.
We will make progress, and we are making progress. And Chris, thank you so much for your part in this.
Thank you.
I think it's so important, and I really enjoy talking with you. And
likewise.
I encourage you all the way.
Great, thank you. And I'm, you know, if people will have my email, they can email if they'd like to learn more, or if I can answer any of their questions, that's not a problem. So.
Great, thank you so much.
And thank you, Bob.
Yeah, thank you. And thank you to our viewers.
Yes, bye-bye, thank you.